Thanks for being here. I feel like this is a bit of a shotgun wedding for some of us, but we're happy to have you and be able to talk directly with you. Two of the big issues that CMS had in their delay was network adequacy and whether or not case managers would be assigned. So I've got a couple questions. One is on case management. And I guess to our three MCO participants, do you feel like that case managers have been adequately assigned, and that people have case managers? Is one of the things we've heard most from our constituents, concern about losing their case manager. And I guess the question is, will you be using existing case managers, or do you anticipate that you'll, at least for 6 months, do that and replace those people with your own case management, or are you going to do a mix of that? And what kind of training are your case managers going through to make sure that they know what they're doing?
So we feel like the case managers are very prepared. In our case, we have 100% of the agencies that are going to continue to provide case management services contracted. Every single case manager that is an employee, which is a small percentage of the case managers in our case, and including the case managers that work for agencies that we're contracted with, have all been trained thoroughly. They've been through system training, they've been through process training. That continues to happen. We have assigned every member that we have to a case manager. If that case manager was still available through an agency or as an employee of ours, that member is still with the case manager they are with today. In the event that case manager has left and is no longer available, obviously we've had to reassign members. So in any situation where the case manager is available to us, the member keeps that case manager, because we believe that continuity of case management is very important, because that's a very key role for these members, and we want to make sure that there's someone who's as familiar as possible with the service plan in place for the member.
And I'll add that's true beyond, you asked about the 6 months, that's true beyond the 6 months as well. Mm-hmm. And we also have all the case management entities that are with us, and of course there's a prescribed period of time for 6 months, but that also, so we will more than likely continue those processes with those case management agencies beyond that. So there's no magic cliff of beyond that 6 months. I think that's an opportunity for us to work through that transition, ensure the care is consistent, and we have every motivation to do that. And then, having worked then with the case management agencies in this period of time, all 70 of them, it gives us a chance to understand them, they understand us, and but I also then agree that the training has been absolutely extensive, and we very much feel we are, in fact, we're chomping at the bit, you might say. They're ready.
Is training in-person training, or is it on the web? What is the training?
It's a variety of pieces. We're trying to figure out if we can speak for each other, but I think we're pretty consistent on that. I think it's a variety. It is web-based. It is direct. It is sometimes in meetings, sometimes with IME meetings. So there's been a variety of opportunity and a variety of ways to get at it. And sometimes people learn differently. So sometimes it's in person, sometimes it's electronically. So basically, if we get a request for any kind of training, we will honor that request. We will meet them where they want to be. We'll go out to wherever they are. So I feel like this is it's one of the essence of managed care, and is the case management coordination component. So we will do whatever it takes to ensure that consistency in care management.
Thanks. The other question I had was network adequacy. We have about, I think we learned over a number of weeks that we have about 30,000 Medicaid providers, and those Medicaid providers have become Medicaid providers over years and years of making the decision as to whether or not they want to be Medicaid providers. And now we've inserted this very red tape, bureaucratic, kind of burdensome requirements for providers that might want to continue to see Medicaid recipients, beneficiaries, because they have to get a contract with each of you. And so there's some of us are nervous and hear anecdotally that providers aren't signing up, and part of it's not knowing what they're going to get paid initially. Now it's maybe not getting paid enough, and concern about being the only provider in a community that does sign up and have your practice be overwhelmed by people because, so, and we've seen figures that 96, 94, 116% of providers had signed up. Where are each of you at on network adequacy and what part, and maybe they have problems getting providers signed up there, and I think that's understood by you all. Can you talk about challenges to getting these 30,000 providers actually working with you and the hurdles that we're going to face if they don't?
I can start. So I think this has been a journey, to be honest. I mean, I think it has been a evolving process, but I think we are, I know we are there. And there are a handful of provider systems, and I mean a handful, I'm talking 5, that are not on our network. And that measure and that CMS component piece that was very extensive, it's unprecedented in my long and getting longer career in doing this kind of work. That drilled down on that matching and who the providers that members have seen around the state of Iowa, we have them in our network. So we're at about the mid-90s range, if you're asking directly the percentage. So that means that if 100% is who are the providers your members have seen, so we have almost all of them in.
Yeah, I'd say we're virtually in the same place. I mean, we all have slightly different providers in some places, but the process of going through and matching where our membership has utilized services and who they've utilized services with has allowed us to ensure that those key providers across all different provider types are in our network or that we're actively working. I mean, there's no doubt that Dubuque is a pocket that still needs development, and I can say we're aggressively working with providers in Dubuque to have them join the network. But at the core, what we know is that our members will still be able to get services, even if a provider's not in our network in that area as we get started. But we won't stop working in the area. But that's really where the whole is right now. We have a very comprehensive network across the state and across all types of services.
The only thing I would add is really a request for support to encourage providers to participate and to work with us at where there are some of those holes. And as we've acknowledged, the Dubuque area, our efforts are thoughtful in nature, and our interest is to come to common ground with providers. And so where possible, we would ask for assistance to encourage those providers to come to the table. We would welcome those discussions.
Senator Yoakum. Madam Chair, well, to dovetail off what you just said, I just had doctors not from Dubuque, from other areas of the state in the office, and they are in the same boat, that they have not signed contracts, reimbursement rates too low, or not getting the information, requirements on prior authorization, a whole list of issues. So it's just not Dubuque. I do think there's a systemic problem. So let me begin with this. I am a parent, a guardian, and I've received one communication so far, and that was to inform me that my child could keep her case manager for the next 6 months. That's it. That's all I've received. No packet, no ID yet, no nothing. So I'm assuming that's still coming. Hopefully it'll arrive in my mail this week when I get home. But as of right now, I have no information other than my child gets to keep her current case manager for the next 6 months. And I'm not the only parent or guardian in that boat. I can dovetail off Senator Bolcom and say that I've also talked to providers who have said they've been taking Medicaid for many years, and the reimbursement rate has been rather stagnant, even though their costs have continually gone up to provide that service. They are now in a position where it's been kind of easy for them to say, I'm not going to do Medicaid anymore, and they're going to walk. So now we no longer have access. So that's an issue that all of you need to deal with, not just those of us sitting at this table, to encourage our providers to sign a contract. Because the prior authorization's problematic, the reimbursement rates are problematic, the issue that we have 3 different billing systems, 3 different credentialing systems, 3 different everythings. And why we didn't centralize all of this, why the 3 of you MCOs didn't work with IME to centralize those very issues of billing and credentialing and prior authorizations to simplify this for all of us. I don't get. So you can answer that at some, well, go ahead. Is there a reason why we haven't centralized these issues?
I don't think there's a reason why we haven't centralized those issues. We have worked to centralize a number of things and to be on common ground, and frankly, in more things than I have seen in my experience across what we naturally think of as competitors, but our colleagues in this program. Now, that doesn't mean to say that everything has been centralized, because it has not. I do think there's an opportunity to continue to work towards those items as we move forward. Some of the things that you speak of are things about credentialing standards that we're required to have ourselves, so NCQA. We have to go through some of those processes.
All of you have to follow the same standards?
Right, but we have to do it ourselves. We can't just rely that somebody else did it in some cases. So a lot of it is so we're required to have that NCQA credentialing. So I'm don't take me wrong, I understand your point. Some of them are harder to accomplish than others, but I don't think that means we can't work towards that over time, because there's a re-credentialing process that continues to happen. This won't be, and providers always go through that process. I mean, there's a routine process where they get re-credentialed on a constant basis to ensure quality to the members. And that's, at the core, that's what we're about, is ensuring that we have quality providers that meet standards to serve our members and to make sure that they're getting the care that they deserve.
I'll just add that I would agree with Cheryl that in Iowa, and in the experience that some of us have even around the country in different states, it's a very high collaboration of our 3 plans, and actually it's refreshing, and it's great. And I think we have committed to working through, are there some ways that we could work together, figure out some of those streamlined processes as we move through this. I think we're highly motivated to do that.
Back to providers and adequacy of the network itself. We have painstakingly gone through just Dubuque and have found that on your lists, we have found in one instance, out of 272 providers listed, 88 duplicates. In another one, there was 400 providers listed. There were 126 duplicates, and those are the kinds of issues we are now facing. So when are you going to get that list cleaned up, that when we access that information, we get accurate information? And let me just read you, and you can all respond then, from one of the providers in my community that wrote, if I can find it here quickly. And it was someone who provides specialty services. Here it is. Dubuque providers are receiving calls from members wishing to set up an appointment after April 1st. The providers service a specific group of Medicaid members, such as only pediatrics or only elderly waiver, but they're receiving calls from members not in those age or in those waiver groups. The members note they are getting the misinformation off the MCOs' websites where they search for providers in the area. One Dubuque provider who is signed with all 3 MCOs checked and noted they are listed as a 0 to 99 age range general provider on United's website, but only provide pediatric specialty services. The provider would like to know what DHS and the MCOs are doing to verify the information online so that members and families are not wasting valuable time calling around to providers who do not provide those services.
We appreciate and want to hear from providers when they believe that information that's on our website is not accurate. We do rely on providers when they fill out the application that they provide to us, that they supply that information. But there are a multitude of avenues of which they can get that information corrected should it not accurately reflect the services that they're providing. And so we encourage them to outreach to us, and we will get that information corrected. We will validate what it is that they need corrected and ensure that it is reflecting accurately on our system.
And also eliminate duplications?
Correct.
Okay. Anybody else
Same-
want to
same
speak to
answer.
that?
Same,
Okay.
same comment.
Also have heard, Ashley, that MCOs are noting that even if they wish to not reimburse a provider at the 90% rate, they're not allowed to do so because of the contract that they have signed with the Department of Human Services. Is that true, Mikki? That even if a provider wanted to not reimburse at the 90% level, starting April 1, because they're out of network, that they can't do so because of the contract and the
So
way it's
you're
been
talking
written?
about a single case agreement, is that what you're trying
I'm
to
talking
address?
about the 10% ding that providers get for not being in network.
If they're out of network, they will be at 90% as.
So even if the
worldwide.
MCOs wanted to reimburse at 100% level for these first few months until we have an adequate provider network, they aren't allowed to do that, is that correct?
I believe so.
Okay?
I do want to interject one thing if I can, ma'am. In terms of centralization, I spoke about the billing forms being across all of the plans. In addition to that, we do have a universal form that we have come together for credentialing. So the basic information for credentialing for providers, that form is consistent. The incident form that the state uses for incident reporting is also standardized, and we're working towards several other examples that I could give you in terms of centralized. So when it becomes aware or attention, we are already starting to centralize where we can and consistently utilize forms and/or systems across all four of us.
Okay, so then let me ask you about the incident report, because I got that question as well. The background for the past couple of weeks, providers were hearing that the MCOs and DHS had agreed to use one standard major incident reporting form. In fact, some providers had seen a final form, only to be told this week that DHS wanted to make changes. Now, DIA also will be using their own form. What is the department doing to ensure duplications and extra burdens are not placed on providers?
We are using the state's, the DHS's incident report, and the MCOs are moving their systems towards our form. So there is consistency to the form that all of our providers have been using for years. They're going back to the state's incident reporting form, because when we looked at that form, we wanted to ensure that there was consistency across all three plans in the state, as well as not only that consistency in the information that we were taking in that form. Our form is also one that DIA is used to.
Okay, well, DIA apparently had sent an email to that same provider saying they were not going to use that form, they were going to use their own. So we need to work through that.
Yep, I will follow up.
Okay? Let me ask each MCO, how many subcontracts do you have, each one of you? And what kind of a service is that subcontractor going to be providing? I know you're subcontracting with transit services. What other kinds of services are you subcontracting for?
Oh, I see. So transportation is probably the largest one, vision,
Vision?
and pharmacy through ESI, our pharmacy entity. I think those are the primary ones.
So you each are subcontracting three subcontracts.
We have other subcontracts, and I probably can't tell you the exact number, but those are the primary subcontractors that really interact with members, that do direct service to members.
So then all the providers not just have to have your information on prior authorization and billing, so they have to have the subcontractors as well?
It's usually different providers. I wouldn't say always, but typically different providers.
Will the subcontractors are you going to require them to have the same kind of prior authorization requirements, or are they all going to be different for the service they're going to be offering?
They'll be in compliance with what the benefit plan is for the program as far as what types of services they cover. And then I would imagine that there could be slight differences in the prior authorization requirements, just like there are slight differences amongst us. I don't believe those are extensive differences.
I don't think they're extensive, yeah.
United?
I would agree.
You have three?
We actually, the exact number I could get absolutely to you.
Please, if
But-
all three of you could get back
You
and
bet.
let us know how many subcontracts you have. I'm going to ask one last question. I'm trying not to dominate, and I am, I'm sorry. Last question from another provider. Currently, we are not able to access client MCO assignments. They need that information in order to help their clients set up, they need to set billings on a timely basis to minimize cash flow interruptions, help members line up transportation as quickly as possible so they can keep their appointments during at least the first 2 weeks of April and beyond, and to make sure services are not interrupted. And this is from someone who offers behavioral health services. So they're saying that the only way they can access the client MCO assignment is done on the ELVS line through IME, and that this information will not be available to providers until April 1st.
So the ELVS line is updated at the end, right around the end of the month. As we said, we send them a major file. We will update the ELVS line. If someone would want that information sooner, they can call member services.
I think they've tried that. It hasn't worked well.
Okay, we'll go back and follow it. But ELVS will be updated just right before the April 1st date.
So then, let me just go on then, because this is a dilemma these providers are facing. If that means that they have to verify, they will have to verify the MCO assignments for some 900 members, and according to their calculations, this would require 30 hours of staff time, assuming that access can be acquired at the current level of availability. If most providers are like us, they too will need to access the ELVS line. If this is true, we would anticipate an unprecedented number of calls to the ELVS line. Suppose half of the 560,000 members require 2 provider phone calls to ascertain an MCO assignment. Each provider can only verify 7 member assignments in one call. Does the ELVS line have the capacity for over 80,000 phone calls in a week? That's 2,000 phone calls per hour, per 8-hour day for 5 business days, assuming there are no interruptions.
So let me walk back. First of all, February 28th, that's right, was the first time that we sent one of the MCOs, what's called an 834 file with information on it. That file would have had people who were tentatively assigned and or who now have made selections. So if members have done something between February and today on the ELVS line, providers can look that information up. In addition to the ELVS line, there's also an online portal that they can go on and they can see if there's, who the member has selected for the MCO. So there's a couple ways in which the providers can look for members, and some of our providers are doing that right now, knowing that many of our members have made choice between February and this time period.
Okay, well, then, let me just say that this particular provider said that a majority of their Medicaid clients have either not been assigned an MCO, they do not know what MCO they have been assigned to, some report not receiving a packet, or they have discarded their packet, and they simply don't know where they are anymore. So I can give you that information for this provider, Mikki. Sounds like you need to get a hold of them because they seem to be having some serious issues with their clients with behavioral health issues.
We'd be more than willing to look that up. I also would like, if you will, Senator, just a moment, in terms of the question on duplication. In fee-for-service today, just like we do now, we do have duplication in fee-for-service, and I'll give you a couple examples. If we sign up one of the large healthcare systems, they may have multiple clinics in multiple regions in the state. We count those individual areas as an access point for us. Same way with waiver providers, we have a waiver that might provide care in 3 or 4 counties. We will count that access point in those counties as that provider going to different locations and different clinics. So there's where you'll see some of that.
Okay, so that means that you may have a doc that's in this clinic, and they may serve 4 other satellite clinics, but that doc can only be in one clinic at a time.
Right, but like, for example, the University of Iowa, Mercy Health Systems, Unity Point have multiple clinics all over the state. We don't count Unity Point as one. We count them in the clinics and areas that they have throughout the state.
clarification was not of the nature you're speaking.
Okay, thank you, Senator Yoakum. We have several people who have questions. We only have 20 minutes left here, so Johnson, Dotzler, Allen, Sigabart, and Reagan. So let's start with Johnson.
Thank you, Madam Chair. Thank you, Mikki, Kim, Cheryl, and Cynthia for being here. For the MCOs, how many states are you working with right now?
We are in 19 other states. This is our 20th.
19.
We're in 16 other.
We're in 25 states today.
Anyone working in Kentucky? No.
We are.
Oklahoma?
Soon to be, hopefully.
Are you in Oklahoma?
Soon to be, hopefully.
Soon to
I
be.
think
What's
that's
going
important.
on in Oklahoma? We've got to have one time in order for the volume to work right, okay? There you go. What's happening in Oklahoma? The House there passed legislation to cut 111,000 people off of Medicaid. They have a $1.3 billion budget hole.
I cannot speak specifically to Oklahoma today, Senator. Certainly from an Iowa perspective, our focus is on ensuring that we're ready to deliver to members on 4/1 for Iowans. And so my focus has been a commitment to ensuring that we are ready for 4/1 here in Iowa.
I'm not sure that's an answer, but I'd sure like to know what's going on down there. Are you hiring staff in the state, the MCOs? And where are they coming from?
So I think we're all hiring staff. Numerous amount of Iowans are being hired, so they could be, by and large, very experienced folks who come in to work with us, or they may be individuals that are new to Iowa and coming in. So I think all of us have done significant hiring all around the state.
Right, okay, so let's just say long-term care. Let's say that you hired 1,000 staffers from long-term care facilities. Where does that leave the long-term care facilities?
I don't
And
know.
we have I'm just wondering, you know.
That's a great question, yes.
There's a balance that needs
Right.
to be struck here. There are needs that need to be met.
Yep. And clearly, there's only so many people, and the services have to be delivered as well, and I don't think we would deny that at all. We all have probably hired people out of a variety of different facilities, and we've all hired people that sometime in their past life did direct service, but haven't done direct service for a long time. I unfortunately am not in the position to answer exactly how each provider is handling that or know exactly where. I don't doubt that that's a resource drain issue that everybody's dealing with, and I think we're all interested in working together and finding solutions to that.
Well, I know, well, Kim, you have your company has the largest number of states that you're working with, 25, I think, right? Is that right? Any of those
Correct.
states doing legislative oversight? You know, it seems to me that the oversight that we have here without some legislative action are your shareholders.
So our oversight today in states is really through our state partners and the legislators in those states. And we do look to work with our state and federal partners, but also, again, the providers in the community to ensure that we're delivering those services. So today, from an oversight perspective, we are in full support of working with our state and federal partners in an oversight capacity.
Yeah.
Would you have any objection, let's say, we had a presentation here from Mikki last week, that if any company were to receive a written warning of not being in compliance, would you have any objection to legislators knowing that? I'm sorry, it's not us.
That there's a, you know, that we know that there's a red flag somewhere? Do you have any problem with that, or is that operating anywhere else in, you know, with any of the states that you're working with?
We do work with states today that share information on the performance of the managed care organizations that they're working with today. Again, our commitment is to our members and to serve the members, and so quality delivery of care is very important to us. And so demonstrating that performance is certainly something that we are supportive of.
Okay, well, I'm going to go to 30,000 feet now. The legislature was not consulted by the administration with this transition, in the opinion of many, a very rapid transition. Perhaps only the only state that I know of that might have been done more quickly, from my understanding, is Kentucky, which was in 6 months, and now everything's in disarray there. Why are we doing this? From your perspective, I don't care about what the administration says. Why are we doing this? Why do we, why are we doing this? That's my question.
Well, let me give it a try. So having worked in this area for almost 30 years in my career, starting in Minnesota, I'm originally a Minnesotan, and 30 years ago when Minnesota began managed care, I worked for the state. So I've worked on a county level, a state level, and actually most recently CMS as well in the implementation of the Affordable Care Act. So the commitment around providing access to care and coordinating care are the component pieces. If you ask me personally, why are we, what is your personal commitment around that? That is what I have seen in the trajectory of these years, is that opportunity. Really at the core of it is that coordination of care and ensuring that vulnerable people have access. And that there is a means to provide that for them in an efficient and effective process that has been, I guess I'll say have been proven in the different states, the 36 or 39 other states or whatever that have done this. So I don't know, I'll leave it at that, I guess.
No, go ahead, do you want to go?
For me personally, and I do want to share a personal story, so as a native Iowan who is a nurse by education and training and has had the opportunity to deliver care in the community here in central Iowa, and also as someone who has had a family member that has received services from Iowa Medicaid, I can tell you that if I could turn back the clock and deliver those services to my family member that we're going to provide to Iowa Medicaid members when we go live, I would be thrilled. The coordination of care, the access to the commitment to that person-centered care, which I can attest that my family member struggled with. And if I could deliver for my family member the coordination and the resources and the programs that we're going to be able to deliver to Iowans, that is what I would want for my family member. And I'm excited and thrilled to be able to deliver the level of service that we're going to be able to deliver to Iowans.
One last question. So what happens in a couple of years when, and the state expanded its coverage of Medicaid under the Iowa Health and Wellness Plan? So what happens when the government, the federal government's share of those costs starts to decrease? What happens under managed care? How are we going to address that problem? Successfully? That's a lot of money.
So I would say, and I'm sure we would all agree, is that we're in it for the long haul. We're in it for the long run. And that's, it's starting this, and you build from this base, and you put these programs in place, you work toward those efficiencies, and you get, you build upon that capacity and that trajectory of a successful program, ultimately.
Thank you, Cynthia. I think it's worth noting that you started working in Minnesota in managed care 30 years ago.
Do I look younger than?
No.
Than
My point is, no, 30 years ago, but we're trying to get 560,000 people through a system in 1 year. I really, that's my concern. I think that's a concern of everybody. Thank you, Madam Chair. Thank you for being here.
Thank you, Senator. So we have Dotzler, Allen, Siegebart, Reagan, and then if I can throw an extra question in the end. So Senator Dotzler, please.
Thank you, Madam Chair. Thank you for being here to answer our questions and face them. I think all of us being part of this committee's got a series of emails from people who are very frustrated with what's about to occur, don't have answers. And so there's just one that I'd like to talk about. this person named Cindy has an adult son who's physically disabled from birth, and extremely complicated diagnosis. She has been trying to do all the right things and get signed up, and she doesn't have any of her information. She's called people. She can't seem to get answers. And she was at an appointment last week with her son's orthopedist. And their office said that they had applied to all 3 MCOs as of last week. They have no information on reimbursement rates. They have no idea won't be covered and what will be covered. And Cindy goes on to say, you know, it makes me feel real comfortable not to know even what the providers aren't getting any information along with us. And she said that, I hope your committee can ask some questions about these issues and get some real issues, because the stress this is putting on families is unbelievable. It truly consumes every free moment, and I am scared to death what the future holds for our son. So I hear you talk about quality of delivering care and about access and coordinating care, but us as senators are hearing something exactly opposite. We are not hearing about quality of care because they haven't got it yet, and their providers are being told, maybe you need to look for somewhere else because I'm not signing up. Or the access to care where they can't figure out where to go. I got letters from other individuals that live in Sioux City that they don't know where to go, and this woman was told by her doctor she needed to go find a new doctor, and she's got a disability that she's afraid to even go out of her house. She's had the same doctor her whole life. I've got other people that can't find transportation. And you talked about outsourcing transportation to a cab company. When people have profound disabilities and mental disabilities, and they're expected to get in a cab and go somewhere. So, I don't know, you know, it's no sense asking what the answers are, because I hear that things are going to be good and people are thrilled that they're going to provide service to 560,000 Iowans. But them same 560,000 Iowans aren't getting the answers. They tried to call. They don't have their cards yet. I know they're coming. April 1st is coming also. And the stress putting on them is unbelievable. So we sit here and ask you and try to find out what we can do to help make this thing work and give you some advice. But the reality of the situation is, come April, there's going to be, as this woman put it, this is going to be pure chaos and a nightmare for her and her family. And the other 560,000 Iowans, hopefully that it won't be a nightmare for them and they can find the help they need. So I'm going to end there, but I just want to ask you this one thing. What is going on with these providers of not getting information about what their rates are and what's going to get covered and what isn't? Because Cindy wants to know, because she can't get the answers anywhere else. And she said, I hope that you could ask these questions and get real answers, because we can't. So can you at least answer that part for Cindy and her family? What her provider, when her provider's going to get information to know what her child's going to get covered and what isn't?
So I'll make an attempt to start that. If a provider has reached out to us and we have not reached back out, we definitely want to be talking to that provider. And I'm not going to say that never happens, because there is miscommunication for a number of ways. But if that provider, I'd be happy to take that provider's name and follow up on that, and we'd be happy to escalate that at any time for a provider. And that's an unfortunate situation if it happened. At the same time, what we do provide providers or people attempting to join our network or inquiring about it is we provide the information about the benefit plans and about how to work with us. And does that information necessarily answer every specific situation? Not always, because the nature of the business is that we want to treat every case and look at the clinical situation of that member and understand what that member's needs specifically are. One of the benefits, while it may not feel like it may not be visible today, of managed care is that we have some flexibility to do some things beyond what has been allowed previously. But in no way do we want to take away anything to a member that they have had available to them. And we have no incentive to not contract with a provider who wants to contract with us. We have a lot of incentive to contract with any willing provider that's ready to do that. So I would be happy to take information about that specific provider, Senator.
Okay.
But I would tell you, we have tried to do a significant amount of outreach, and we continue to do that every single day, and we're committed to that.
Well, I appreciate your answer, and I know we're running out of time, but the truth of the matter is there's a real disconnect, what we've been hearing all along at this end of the table from what we're hearing from our constituents. And this, I rather doubt that this is one single incident, because we all have got a bunch of different ones. And so I do appreciate your answers, even though I don't think it's an isolated incident. I think this problem is systemic, and it's really going to be a huge problem and continue to be. So thank you, and thank you for your...
Thank you, Senator Dotzler. Senator Allen.
Thank you, Madam Chair, and thank you all for being here. My question is pretty straightforward. The issues I've dealt with through this process have been somebody being denied a medication because of a process error. Behavior clinic that's, 9-iron from bankruptcy because they're not getting paid. A patient of a 30-year-old that's got multiple disabilities needs to live with assistance, and they lose that assistance for a period of time because of a paperwork error or whatever. So I have a process now where I go to Senate staff, and Director Stier's group is very responsive, and they take care of these issues, and within a couple of weeks, everybody's back on track. As a senator, as a mayor, as a council person, and these people come to them, who are they going to call? I mean, right now, we've got a direct line to basically who we need to get to. I've got 3 people sitting there. Who am I going to call? How am I going to know what to do to get this person help?
Well, if, you can certainly call us. I will say that we have been very open to doing that. Our government relations people, in terms of directly, may perhaps asking your question, but we have call centers. The call centers are linked to our Iowa-based case management process and structure, and so those are the kind of mechanisms in, if you will, in terms of resolving that. And I think as others indicated, we have every interest to resolve. We have every interest to work with providers. We have every interest to do that. That is what we're here to do. So it is a very strong commitment.
I don't have any doubt you have interest to do that. I'm sure you do. But, I mean, right now I've got a direct line. I mean, this is kind of an oversight question, I guess, if you will. I mean, how does this, and having gone through this on July 1st of 2000, with a phone company changing over from GTE to the place I worked, Iowa Telecom, and the call centers, I can assure you, I hope you have a lot of people that want to work 16 hours a day and take jobs they didn't plan on doing and start answering those phones, because having been through that and thinking my job was something else, I became a call center person for 3 weeks to get through this. So I believe that's what we're going to see, and I need to know that these people here in my district, I can call or get a hold of somebody right away and get them on the process so that they're comfortable that they're going to get the services that they believe they needed. So, thank you, guys.
Thank you.
Thank you, Senator Allen. Senator Siegebart.
Thank you, Madam Chair. it's sort of a history question I have here. When we started this a year ago already with this idea, I was told at that time that people that were already in the system, that were already getting Medicaid benefits, were automatically re-upped into the new system. Now, has that happened? If I'm currently, say I'm 85 years old and I'm in a nursing home and I've been getting Medicaid for the last 5 years, and I've been in the system and they've been working with it for that long, did I automatically get signed up? And so have you been, the people that you were assigned, have you already put them in your system? So even though they didn't get maybe their card yet, they're already in the system, but they just don't know it yet? Is that possible?
Yes, absolutely. We have every member loaded in our system and ready to go at this point. Every member should be receiving cards this week, I think by Saturday or Monday or somewhere in the latest timeframes. But yes, everybody's in the system and ready to go, so there's no issues there at all.
I'd also like to just add that eligibility is not determined by us.
Yeah.
It's determined by the state. So if that member has been eligible for 5 years, they remain eligible to the extent that the state determines their eligibility. The card, we get that information from the state, and they're in our system. So to the extent that we've gotten that member from the state, they're in our system, and the card is on the way.
So can you tell me how many you have in each one of your systems already signed up? Do you know? If there's 560,000, remembering that we only expanded Medicaid 2 years ago, and so we went from 300,000 to 560,000 when we did that. So those 300,000 that were there before we expanded should be in the system already, I would think, so.
So we have 173,000.
173,000, okay.
We have 188,000.
188,000.
181,000.
181,000. I didn't do the math. And so that would seem like that's over 300,000 considerably, so thank you, appreciate that. One more fast question. I know that you were born in Iowa. Where are the rest of you, and where's your current residency at? Are you going to live in Iowa for a while, or is that that goes with the territory, or?
Goes with the territory. So I am originally from St. Paul, Minnesota. I grew up way up north in a very rural area in Minnesota, but I live in West Des Moines.
Okay.
I'm originally from Columbus, Ohio, but I've lived in Iowa since 1995 when I moved here to do the beginning of the Magellan program.
Okay.
I live in Norwalk, Iowa, so Warren County, and grew up in Polk County, was born in Des Moines.
You don't know how good that makes me feel. Appreciate that.
My kids went all through school here. If I'm not an Iowan, they are. So.
I have kids in the school district today.
Yeah.
And
Thank you, ma'am.
I personally have spent a lot of time, with the neighboring state piece, but lots of time, relatives, and lots of time in Iowa. So it very much feels like my home as well, so.
Great.
Mikki, how many total people are on Medicaid?
It vacillates. We have approximately, I will verify that number for you and get that to you rather
Because
than that.
this totals 542,000.
That's correct.
So we've been thinking 550.
Yeah. We have we have a churn that occurs, and we see a higher churn happening between the months of January, February, March. So we have that percentage that comes on and off of Medicaid on a routine basis, so that's right in that ballpark of where we would have, but I will get you a solid number.
Okay.
I also wanted, if you would please like to clarify, to your point, sir, if there are concerns about members and issues, during this transition, you can still reach out to the Department of Human Services, and we will continue to expedite and move as quickly as we can. We do want to ensure a smooth transition. We do want to answer the issues, and we will continue to, be available to assist.
Senator Reagan.
Thank you, Senator, or Madam President, Madam Chair, sorry. It's been a whatever.
Her back is out. Do you think you can help her?
No, I'm in pain, yeah. Anyway, two questions, and I wanted to make sure that all the group had time to get theirs, but will you have your own clinics? And the second one is the outside around the state. I'm Northern Iowa, have a lot of people needing services and are very accustomed to utilizing some of the Mayo Clinic facilities. My understanding there are no contracts with them at this point, and so just wanted those two questions answered. Thanks.
So I could start. We are happy and willing and have contracted with what we call the border providers, meaning around all the borders of Iowa. We continue to pursue opportunities to do that, specifically to Mayo, which I know has been a significant concern and a valid concern. We have the 3 Mayo clinics that are located in Iowa. They were willing to contract with those. The hospital has notified all of us, and you guys can chime in if you need to, but the hospital's notified all of us that they do not wish to be a provider for Iowa Medicaid any longer, which is unfortunate, and we hope to change that over time. However, we certainly recognize the need for some of our members to be at Mayo, and they have agreed that they'll do single case agreements, meaning they'll do a case by case, and we'll negotiate rates with them on a case by case basis.
So what was their reasoning?
We didn't get a lot of reasoning except that they just made a business decision. That
So
they
at
didn't
this
wanna
point,
do
they're
that.
serving people, but now there's business decision.
That's our understanding.
Happens, but.
Right, and we will continue to pursue that. We very much would like to have Mayo in our network.
I would too.
Same for us as well. Yeah.
Same for us as well. I would comment regarding Mayo. Their intent is to really obtain that tertiary care and to be the source, not a primary care provider for Iowa Medicaid, but yet a tertiary care provider. And that is their commitment to work with us on a case-by-case basis as we have members that have needs.
And then on the clinic?
We do not.
Clinics.
Oh.
We do not have
Don't need
any.
it.
We do not have any owned clinics.
Plans to do that.
At the present time, we do not have any plans to have owned clinics in the state of Iowa.
So we have a clinic, it's called CareMore, it's located in East Des Moines, but it is a clinic that works in high collaboration with the provider systems, and in fact, conversations have been working both with the major provider systems and the community organizations and community FQHCs, et cetera. And it is our intent to have that one, and it is an intensity place. It serves what I refer to as sickest of the sick. Their model is all around that very intense, very difficult to serve because of, if you will, because of the multiple issues that may impact that person. So it is meant as not to supplant, but to supplement, and it is around, and their model is a tested model in terms of the kinds of patients that they work with.
I think that's something we'd like to hear more about down the road.
That would be fine.
And we do not have any clinics, and we do not have any plans to. It's not part of our business model anywhere.
Thank you.
Okay. Where are your call centers located? The people who call from Iowa, where are those calls going?
For Amerigroup, it's in Virginia Beach, Virginia.
Ours is Philadelphia.
Our member call centers in Davenport, Iowa.
How many other states does Virginia Beach serve?
All of our business, all of our Medicaid business around the country.
So the number of states that you said you were in business with?
19, this is the 20th.
So our 560,000, well, your carve-out of that 560,000, they're all vying for answers from one call center that's from all of those states.
So there's a dedicated Iowa team at the call center that are trained in Iowa, actually trained in Iowa culture, Iowa, the state of Iowa, and they are dedicated to that service group. Yeah, I know.
Can you relay to them that we're on Central Standard Time, because most of them ask why? And is yours the call center the same? How many other states serve?
Same thing. So we have a call center in Philadelphia. We have one in Jacksonville, Florida as well. However, the Philadelphia office is servicing this program, and we too have a dedicated team that serves this program that have been trained specifically on this program. We do use, for the ramp-up time, when you do expect higher call volumes, we've also trained additional people outside that dedicated team that'll help with the higher volumes in the beginning, but there will be a consistent dedicated team, and Again, just like that, trained on this program. We actually have somebody here locally that goes and does that training as well, participates in it and oversees it to make sure that it's got the right messaging. And yes, we will make sure they talk about the right time zone.
Ours is in Davenport, Iowa, so
Okay.
we have Iowans that are employed in our Davenport location, and they are living and breathing in the central time zone.
Okay, so that's a good thing. Okay, so here's my final question, and we probably need to leave because appropriations is coming in. This is $4.2 billion. Iowa taxpayer money. How are you establishing yourselves as an Iowa business? How are you establishing yourselves as an Iowa business serving Iowans here, dedicated to the state of Iowa?
United Healthcare has been committed to the state of Iowa for over 30 years, and we've been serving Iowans for that long. We're serving today over 500,000 Iowans through our various programs that are commercial-based, military, and veterans, as well as we have served the Hawkeye program since 2000. Our commitment to Iowans, we are employing over 1,200 Iowans for the purposes of our business. United Healthcare is strongly committed to Iowa. Our commitment is going to live and breathe in our service to members here through this program, and we're excited to expand our presence in the state of Iowa and demonstrate that long-term commitment to the state.
So while AmeriHealth Caritas is new to Iowa, the people working for this program are not new to Iowa. I have only 3 employees out of almost 300 that are not from here. We are Iowans, and we are passionate about serving Iowans, and we absolutely understand the significant commitment we've made to ensuring the health and well-being of the members that we've been assigned. We are participating actively in community events. We're supporting community events. We're helping to fund those in some cases. So truly trying to engage and embrace and be part of the community, and not just Des Moines, but all around the state.
So I would echo the same for Amerigroup. It's the same level of commitment. It is hiring Iowans, whether they're clinicians or operations people that work with us. My executive team, my leadership team are Iowans, and same kind of thing. It is an investment in the community. I mentioned before, we're in it for the long haul. We're in it for the investment in the community. It's people who are part of the community. We have a foundation that we're looking at. Are there opportunities for us to help them support health programs in the community, working with the stakeholders in a very sort of real way, and really helping build a base because we will be here. We are here, and we will be here. So it's a very strong commitment on our part.
Thank you. Thank you all for coming today. Mikki, again, thanks. Mikki Stier, Medicaid Director. And then Kim Foltz, Health Plan Chief Executive Officer from United. Cheryl Harding from AmeriHealth Caritas. Cynthia MacDonald from Amerigroup. Thank you all for your answers. There may be some follow-ups. We'll, again, send those through your government liaison. I would encourage those people who are watching at home to send us questions or to send these individuals questions as follow-through. We want to get this right. April 1st is coming, and everybody just hang on tight. Thank you all, and Senator Bolcom moves that we adjourn.